Delirium. Overview and hypothesis. What is delirium? Delirium is a very common, complex problem, brain-centric phenomenon. Almost always multifactorial. Delirium, also referred to as encephalopathy or altered mental status, is an acute alteration of attention, consciousness, perceptions, biorhythms, emotions and awareness, and with fluctuating symptoms. Delirium is not always transient. It can become protracted or chronic. It is not benign. It can leave cognitive scars, from mild to severe. It is, itself, a risk factor for more delirium. It can be preventable, or mitigatable. Yet, sometimes it is inevitable. Delirium is dynamic and fluid in severity range or spectrum, from very mild to severe. What are some of the key characteristics of delirium? Fluctuations of symptoms, inattention, distractibility, hypoprosexia, disorientation, confusion. Hallucinations, illusions, delusions, memory dysfunction, dysarthria, aphasia, psychomotor agitation or retardation, inappropriate speech, behavior or mood, sleep-wake cycles disturbances, resurfacing of prior neural or, all without other explanations. How does delirium occur? What leads to it? There are several hypotheses. Here, I will use the concept of brain reserve to help explain the notion of delirium. Under certain and individualized stress loads such as physical, psychological, physiological, social, financial, etc., the brain gets tired, does not work or function/compute appropriately. Decreased brain stamina leads to delirium. How much stress can a brain handle before getting tired, before failing, before delirium ensues? The answer to that question is complicated and polyfaceted, but the idea can be conceptualized as follows. A healthy brain can stand a larger stress load before it reaches the shoulder of the curve break point where its organized function falters, becomes disorganized and delirium ensues. Since every person, by virtue of their own experiences, personality, genetics, education, have unique manifestations of their individual delirium. A unique synaptome.
So, if we plot the level of cognitive function over time, where brain function or robustness are traveling forward in time, let it be minutes, hours or days or longer. And, the motion forward encounters stressors proportion the brain function forward. Stressors could be so strong that at a certain point, the brain function and robustness decline, leading to delirium. Conceivably, if the level of the stressors and risk factors decrease, the brain function could return back to its prior level of function. In an individual that already has a lower level of cognitive function or robustness, encountering stressors leads to a decline in cognitive function that occurs earlier and potentially faster and deeper. We can call the inflection point, the shoulder, when the cognitive function declines, the break point. When the cognitive function is not as robust, the recovery will likely be slower and potentially also to a lower level from the prior decline. Although it may seem reality, cognitive function fluctuates throughout the day, even in normal people. People with risk factors for delirium will have more frequent, deeper, and more difficulty to recover from the down cognitive fluctuations. A brain that is already anatomically or physiologically abnormal, that is, has risk factors, will be less able to handle stressors, before that breakpoint is reached. Any brain can be sent into delirium, just take it to its stressor handling or stamina limits. Hospitals are very stressful places, physically, mentally, emotionally, sensorially, spiritually, socially, etc. Be there long enough and delirium will ensue. If measures are taken to try to get the patients out of the ICU or hospital as quickly as possible and back to less stressful and more familiar environments, or back home, then delirium could potentially be minimized or avoided. The human brain is an evolutionary tool for adaptation to the environment. It allows for very fast adjustments to environmental challenges. Its main function is to gather and handle information, interpret it, and respond to it to increase chances of survival.
The human brain has about 100 billion neurons, and about 5,000 synapses per neuron, hence, there are about 0.15 quadrillion synapses. Each neuron is part of a task, an algorithm. Some neurons are inhibitory, some excitatory, some modulatory. Each synapse, because of its uses, is of different strength and robustness. Synapses involute or even disappear if not used. Synapses are strengthened or even appear by use. The frailer synapses involute not used. This leads to cerebral dyssynchrony. Chronological aging, or accelerated aging, decreases the number and quality of neurons in the synapses, such as when older. Many of the risk factors decrease synaptic function, such as cognitive or physical immobility, severity of illness, etc., use of sedatives, such as propofol, benzodiazepines, opiates, which block or inhibit synaptic functions. Some of the risk factors accelerate brain synaptic aging, or increase their frailty, such as many years of diabetes mellitus, or end-stage renal disease on dialysis. All these neurons are participating in exquisitely timed and connected pathways, algorithms. The mapping of all these connections has been dubbed the connectome. The collection of synapses in a single brain is called the synaptome. Synapses vary in quantity and quality, and their function varies also in time and space, or lack of stimulation. In the 1940s, the theory of use it or lose it, known by the eponym, the Hegbian theory, was postulated, and through the decades corroborated. The preservation of the integrity of the synapses is a very complex, ongoing process.
Cells that fire together continue to fire together. The more fire together, the more the circuit of neurons fire together, the more robust it becomes. A form or cellular circuit habit. Lack of use of the electrical circuit leads to its involution, and the weaker synapses will be the ones to fade first, while the stronger synapses will take longer to disconnect. If stimulation resumes, there is no guarantee the same location as the prior one, therefore the function or outcome of the new algorithm may be different than the prior one. So, synaptic frailty leads to change in connectivity, loss of timing and rhythms, loss of synapses and more difficulty recovering function. The longer synaptic dysfunction is present, the more difficult to bounce back from it, and chronic. Hospital-acquired weakness may have similar pathophysiology and risk factors. Essentially, delirium is a phenomenon of diffuse synaptic dysfunction and involutions. In the CNS leads to delirium. In the PNS leads to weakness, also known as neuromyopathy. Delirium is part of the multi-organ dysfunction of the ICU. Delirium has increased morbidity and mortality, and is not always fully reversible, either. Any confusion or decrease in attention should probably be considered in the delirium range. Interestingly, delirium risk factors seem to be summative in their effects. Possibly, even, logarithmic. That is, dementia, or benzodiazepines can each lead to delirium, but the effect of both together seems to be bigger than either one alone. Some risk factors include older age, frailty, history of prior delirium, polypharmacy defined as 3 or more medications, immobility. Medications such as sedatives, anticholinergics, opiates, benzos, narcotics, steroids, illicit drug use, dopaminergics, diuretics, beta blockers. High number of comorbidities, pain, malnutrition, alcoholism, fever, hypothermia, hypercarbia, hypoxemia, shock, CHF, depression, kidney dysfunction, severity of illness, dementia, Parkinson's, sleep deprivation, poor sleep quality, cancers, cancer treatment, stroke, vitamin B12 deficiency, anemia, urinary catheter use, hip fracture, infections, any surgery, mechanical ventilation, intubated airway, physical restraints, overhydration, edema, dehydration, BUN greater than 18. Electrolyte abnormalities, dysthyroidism, adrenal insufficiency, hepatic dysfunction, impairment of vision or hearing, psychological stressors, social stressors, environmental stressors, iatrogenic. Also, physical, social, psychological isolation, and aging, natural or accelerated.
Delirium may go unnoticed and undiagnosed, yet 30 to 40% of delirium may be preventable. About 50% of hospitalized patients will develop delirium. The consequences, such as increased morbidity and mortality, which doubles, injuries to patient and others, falls, increased length of stay, infections, pressure ulcers, malnutrition, functional decline, nursing home placement, and more. There are 3 types of delirium. 1 hypokinetic, the most common. In the extreme, this type could lead to coma. 2 hyperkinetic, less common. And 3 the mixed type. All patients should be on delirium prevention strategies, and the more risk factors, the more the emphasis of the clinical team on proactive prevention of delirium. An inpatient delirial tool. Only after the non-pharmacologic strategies have been active, then consider pharmacologic management. Some strategies to help decrease the risk or prevent delirium include: during the day, keep room window shades open, reposition bed for more sunlight on patient, lights on, TV or radio on, discourage day naps. Early mobilization. Reduce, as possible, isolation, medication and sedatives, such as opiates and benzos, anxiety, pain, constipation, fever, physical or chemical restraints, malnutrition and dehydration. Mobilize the patient as early and as tolerated and as possible. Therapy activities such as physical, occupational, speech, art, pet, and play therapies. Try to engage family in these activities. Reorient patient to date, time of day and place, BID, to TID, and as needed. Cognitives, for example, reading material, music following patient's preference, massage, pet therapy. Remove urinary catheters, if possible. Screen for constipation and urinary retention BID, perform PR and bladder scans. If the patient uses or needs eyeglasses, hearing aids or dentures, please try to obtain them and put them on, while awake and or as tolerated. Encourage companionship of family, friends, and or sitter, as per unit protocol. Ask the family to bring family pictures, and home bed cover or blanket for the patient to use. Perform a daily medication review to identify continued or the dose is lowered. Verbal encouragement and support TID, and as needed. At night. Environment kept dimly lit or dark, as safely as possible, environment as quiet as possible, TV and radio off, minimize equipment alarms, minimize noise, minimize loud talking, encourage or apply earplugs bilaterally, prevent and minimize sleep deprivation, for example, group nursing tasks. Report sleep and sign out to day nurses, as if it were a vital sign.
The bedside clinicians should include the patient's pain and sleeping patterns as part of the delirium prevention strategies, and address these issues. Pain and sleep both be vital signs. Similar to other measures of quality of care, such as days without UTI, or days without DVT, we should have days without delirium, and the longer the nursing unit goes without a case of delirium, then more meaningful and prideful our work. Essentially, to decrease delirium and hospital-acquired weakness, then strengthen the synaptopathic integrity, when, and as possible. Both are partially accomplished by exercises. In the future, electrical stimulation of brain, muscles, nerves, virtual reality, chemical synaptic activation, etc., may be topics of research. The future looks very promising. As we all age, delirium becomes inevitable, as it is a marker of increasing frailty that comes to all of us via Chronos, the mythical god of time. Thank you. And keep those